Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to introduce to you now. Dr. Amy Goss is an assistant professor of nutrition sciences at the University of Alabama at Birmingham. She is also a registered dietitian and an early career investigator with expertise in conducting randomized clinical trials to examine the effects of diet quality and macronutrient composition on risk factors from chronic metabolic diseases, such as obesity, non-alcoholic fatty liver disease, otherwise known as NAFLD, and type 2 diabetes. The goal of her research is to identify effective, sustainable, and non-invasive dietary means of preventing and reversing disease with metabolic origins. Dr. Goss specializes in MRI and MRS techniques for the assessment of fat distribution and organ lipid content in adult and pediatric populations. She recently has conducted studies using a family-based, controlled feeding experimental design aimed at improving outcomes in children with NAFLD. Dr. Amy Goss was a presenter at Low Carb Denver 2023 and did an amazing job presenting her talk titled Pediatric Non-Alcoholic Fatty Liver Disease, which will be the focus of our chat today. I met Dr. Goss in person at that amazing conference, and it is such an honor to welcome her to Balanced Body Radio. Dr. Goss, welcome to the show.
Hi, thank you so much for having me. I'm really excited to be here today.
It's really such an honor to have you. The topic is so important that we'll be discussing today. It's so unfortunate that we have to talk about these chronic metabolic diseases in kids, in kiddos, young people. Like type 2 diabetes was not always called type 2 diabetes. It used to be called adult onset diabetes. We can't call it that anymore because kids are expressing with it. They're expressing with obesity and all kinds of mental disorders and fatty liver. It's unbelievable.
Yeah, I agree. It's rather shocking, the extent to which we're seeing these types of diseases develop in kids, and it's shocking at the same time. It's not shocking. I think sort of we're seeing all these things develop because we have sort of like a problematic food system in a lot of ways where, certain types of foods that are low in quality are easily accessible and cheaper and they taste good. So, it's sort of like, it's shocking, but it's not shocking at the same time that we're sort of seeing this crop up in kids, these diseases that we once thought, kids were protected against, at least for, an extended period of time, maybe until they were adults. But if I've learned anything from doing research in this pediatric space, it's that, this is definitely a concerning issue. We see lots and lots of kids in our studies that have severe metabolic health problems. So yeah, I agree with you that it's definitely problematic.
When you were getting your training to become a doctor, did you know that this is what you wanted to do, that you would be working with children in particular in chronic disease?
Yeah, so when I first set out, so I have a PhD, in nutrition sciences. And I, back when I started graduate school, I really had no intention of even going for a PhD. I did my training in undergrad in dietetics. I came to the University of Alabama at Birmingham to do an internship, intending to practice clinically, do like inpatient or outpatient counseling and clinical practice with dietetics. It was really sort of being exposed to the nutrition science research side of things as a part of my graduate studies. Almost, realizing how many question marks there were when it came to nutrition and nutrition science and what the science behind the things we were telling people to do really piqued my interest in terms of everything we don't actually know yet and things that we haven't actually, the things that we may be telling people to eat as registered dietitians or medical, professionals, that if you dig into the literature, if you dig into the science of it, aren't, as solid as a rock. So I think, starting in the nutrition science field, and seeing just sort of all of these metabolic illnesses that have been like, just increasing at amazing rates in our society, really just got me interested. I started out with adults, right? Like doing interventions, working with my mentor, Barbara Gower, on doing controlled feeding studies and diet interventions in different adult populations with metabolic disease, including type 2 diabetes, obesity, polycystic ovary syndrome, looking at specifically at glycemic load and the macronutrient distribution of diet and how manipulating that, reducing the glycemic load, reducing a carbohydrate content of the diet can really have these profound positive metabolic effects on someone, even in the absence of weight loss, right? So it was kind of based on these studies that I was like, well, pediatrics may be a perfect population to study this in because, you know, a lot of times when we, you know, certain recommendations and certain things that work in adults, like energy restriction, right? Something that we all know, energy restriction does lead to weight loss. We also know bariatric surgery leads to weight loss. We know certain medications can lead to weight loss, but are these things advisable in a young population, in adolescents and pediatrics? So really, like, my question was, can we just manipulate the diet quality without having adolescents restrict energy, without having them go through these other things, but simply do that, and doing that alone, can that improve their metabolic health? You know, I think there's a lot of reasons why recommending weight loss in kids is a bad idea, right? It could set them up for long-term failure, could put them at higher risk of eating disorders, could deplete lean mass, organ mass, bone mineral density prior to the point in their life when they're supposed to reach peak, you know, peak bone mineral density and accumulate lean mass and that sort of thing. So I think there's like a lot of reasons why specifically looking at diet quality in kids is a really important question.
Yeah, that's very interesting. So based on your training, when you were, you know, learning about all of this stuff, did you ever imagine that one day you would be presenting your information specifically at a low carbohydrate conference, not just the normal conferences that you were going to, but this whole other like subset of the population that is adhering to a low carbohydrate, or in some cases a no carbohydrate diet?
Yeah, I'll say that's definitely something I did not ever see myself doing. You know, it's so interesting getting into the space sort of, and, you know, meeting so many people that are passionate about this type of dietary approach. You know, and I ended up there through research, right? So like back when I was getting my PhD and like doing these low glycemic load diet studies and seeing the results firsthand from our trials and publishing them, sort of like opened this door to where, you know, you start asking more questions like, well, what about this? Like, what about a ketogenic diet approach? What about, you know, different types of low carb diets? Like, just, you know, based on these initial results we had from those trials, really just like opened a lot of doors, I guess, in terms of looking at what was the science behind different types of low carbohydrate diets. And then realizing there's like a huge community of people that that follow this dietary pattern, are really excited about it, you know, see the value of it, and are really doing a great job at promoting it and like making sure it's recognized as a healthy eating pattern for those people that need to follow it, right? And there's lots of populations that benefit from it. So yeah, like, so to answer your question, you know, going back, looking, you know, I would have never imagined. So I didn't even know like there was this community of people there, and then like how excited everyone is, and that they're putting on these types of conferences, right? That are bringing these different people together that have different levels of you know, different types of expertise and that sort of thing. So it was really cool for sure.
That's amazing. This is why we need people like you. We need researchers. It's not like you're getting paid if I eat a steak versus eating a salad versus eating cold cereal. You're just doing the research. It sounds very similar to me to the story of Dr. Ben Bickman, this, you know, insulin researcher who is spending his career and all this time understanding insulin. And he discovers that there is this huge subset of the population that are discovering all kinds of different benefits, really healing all kinds of different chronic and acute diseases by using a low carbohydrate or ketogenic diet. And he just bursts onto this scene of like, wow, I didn't even know like all you people were like meeting up and doing conferences, like just going to different ones too. Yeah, totally.
Right, it sounds just like that. Yes.
Very interesting. This is a bit of a side tangent, but I love asking this question. What, just observationally, when you're at Low Carb Denver, what is the difference in, I don't know, like the vibe or the population or the research? What's the difference between, you know, Low Carb Denver versus attending some of the other conferences that you attend that would be more like conventional?
Yeah, so I think it's So like a conventional conference is, you've got people coming from a lot of different places, and they're presenting research on such a wide variety of topics, and not everyone always agrees, right? So like some people, it's more like, I mean, I don't want to say it like diversity of thought or like diversity of the types of research that are being done. I'm in a very specific area of research. And so when you go to these conferences, you sort of have this like sampling of many different types of research, and maybe like opposing thoughts, and you have debates, and you have all these different things. What's unique, I guess, about like a low carb Denver situation is most of the people there either have like firsthand experience with trying doing low carb. They have a personal experience that they're bringing to the table that sort of led them down the specific path. And there's just a level of like, it's a really cool environment to be in, just because everyone is so passionate about it and eager to learn about it. So I guess it's just, it's such a focused conference. And I think there's a lot of value in that. And it's a great community to sort of be a part of, when you can share your data with a crowd that is going to be really excited about the types of questions you're asking with your research. So yeah, I really enjoyed it. And for a lot of reasons, it was a great experience.
Yeah, it is an amazing time. It's interesting to kind of reflect back on, I'm sitting in the front row, I'm trying to take notes. These sessions that we were doing were very long sessions, talk after talk after talk, of presenting like a lot of really technical research. And you just don't notice, like, the afternoon, maybe a few hours after lunch, people are not necessarily like nodding off. Like, they're still paying a lot of attention. On the front row, I'm sitting next to the MC of the show, and I'm sitting next to the last speaker who just came off the stage. And on the other side of me is the 60-year-old couple. He just had a heart attack last year, and he's on his own journey to healing. And all of us are there just to learn about this stuff. It's quite an interesting kind of subset of the population.
Yeah, I agree.
Very interesting.
Mm-hmm.
Okay, well, offline, I was telling you about a podcast episode from the Daily Podcast. This was released in January. I've literally had to listen to this conversation 5 times now. I've listened to it again today. And every time I listen to this conversation, and the title of the podcast episode was an aggressive new approach to childhood obesity, or something like that. And they were talking about how obesity in children is becoming a huge problem. It wasn't much of a problem in the 60s, but in the 70s, it got worse. In the 80s, it really got worse. She mentioned different studies they did where they took entire, like it sounded like school districts, and did randomized controlled trials where they would go into one school district and teach the kids everything they needed to know about obesity. So they taught them how to move and why to work out, and provided more access to fruits and vegetables. And they noticed that no matter how much they coached this school, the results were exactly the same. And so everything they thought they knew was not working for childhood obesity. So the conclusion that they have come to is that childhood obesity is genetic. Literally saying there's nothing you can do about this. It's a serious problem. You're going to have it. And once you get it, you're not going to be able to reverse it. So again, the American Pediatrics Association, or whoever, is recommending that at the age of 2, you can start to prescribe really heavy nutritional counseling for a 2-year-old, and also for the whole family, and make sure that they understand what exercise does and why they need to do that. It's very expensive, requires lots of different, experts in different fields to be able to coach. At age 12, if they're still presenting with obesity, it's recommended to give kids GLP-1 agonists, I believe they're called, like Ozempic is the big one that's really popular. And at 13, if they're still expressing obesity, we can now do bariatric surgery on these kiddos. What do you think of all that?
Yeah, that's a lot. It's a lot there. So there are certain aspects of that I would have to agree with, right? Like, I think that what we're seeing in kids is part genotype or genetics, part phenotype, right? The physiology that's interacting with the environment or the nutrition side of things. Like, so it's the genotype and phenotype interacting with the environment to result in one, if not multiple, chronic conditions in these kids. I don't think the solutions are simple or easy. But I do think like, I mean, even, I don't know. So from our research, I can speak from like, you know, what I know from our research in kids is that I think manipulating diet alone in a way that's, you know, not too restrictive, can have profound impact on metabolic health in kids. And we can see, like in our studies, we see reversal of metabolic disease with using with diet within our studies and family-based interventions. You know, I have to say, like, for some kids, it's, you know, I'm not going to sit here and say that like for everyone that's going to work, because we do see in our studies like varied responses. Like some respond really well to the diet interventions that we use and we have the families on. Others don't respond as well. So I think it's like, at the end of the day, sometimes like we just have to weigh the costs and the benefits of doing these different types of interventions. So like, for instance, this sort of speaks to like a precision nutrition approach, right? That based on your metabolic phenotype, based on genotype, metabolic phenotype, it determines how you're going to respond to specific types of diets, right? You know, when we randomize kids to whether it's like a low carb or a low fat diet, we see very response. If we look at the averages, on average, what we see is with our carbohydrate restricted diets that our kids with fatty liver respond really well to that diet on average. But within that group, if you look at the individual responses, not all of them do. So, you know, what we don't know is if we put them on some other type of diet, would they be responding better? At the end of the day, like, I think, you know, using a family-based approach for adolescents is very effective and necessary to get all of like the entire family on board to help change the behavior. But yeah, but at the end of the day, I do think it's like a genetic, you know, genotype and phenotype interaction with the food environment that's sort of driving some of these things. And I think that like there are some dietary changes that can be made that could help some people avoid having to take medication the rest of their lives, and also help them from, you know, prevent them from having to have bariatric surgery and things like that. So I don't know if that kind of like answers your question, but.
No, it really does. Part of what makes us human is to be able to leverage different technologies, and we're learning all the time and coming up with new compounds. We're coming up with new surgeries, and they can help for sure. Mm-hmm. And one of the points that this podcast made is like, when you decide to do bariatric surgery, you can't really go back. Like, this is a very permanent thing that you're then going to live with for your entire life. So, you know, we even just mentioned in your introduction, you are trying to find non-invasive ways of changing this through diet. Is that going to work 100% of the time? Maybe not. Maybe compliance is going to be very difficult. Maybe money is going to be a factor. Maybe, you know, sugary foods taste really good. Sweet foods and processed foods are delicious, and they're very cheap, and they're easy to find. They're at the hardware store, for example, like they're everywhere. So is it going to work every time? But like, no, but why are we not at least starting with that? And then down the road, if we still have issues, look at all these amazing other technologies that we can try.
Right. Yeah, I agree. And, you know, not like all of these things, they're not without long-term consequences, like you said, like for the, you know, the new generation of obesity medications that are on the market now, you know, there's so much we don't know still about the long-term efficacy of them. You know, are there going to be some sort of unintended consequences? That's a very real, you know, question that a lot of investigators still have. You know, fully acknowledging that maybe there aren't, you know, maybe it's going to be perfectly fine, and that truly is as good as we think it is. It's, you know, designed to be. So, but like you said, like bariatric surgery has its, you know, benefits, but it also has some long-term consequences, or, you know, long-term maintenance things that have to be considered before, you know, fundamentally changing your GI tract and the way in which you know, metabolize food, and, you know, what type of, you know, diet you have to be on for the rest of your life, regardless of whether you have surgery or not. So yeah, I mean, I think, you know, I'm hopeful just because from what we've done and what we've seen in our trials, that diet alone can be a really effective tool to help kids and families set them, help set kids up for long-term success and avoid going down the path of developing other related chronic metabolic diseases like type 2 diabetes or metabolic syndrome and things like that.
Yeah, that's a great point. And I'm so glad you mentioned that. That would be a perfect segue. I was wondering if you could define for us the difference between a chronic metabolic disease and something more like an acute disease that would send me to the hospital. What are the differences there? How do each of those work a little bit differently?
Yeah, sure. So when we talk about like a chronic metabolic disease, it's really, we list off things that essentially it's a disease that's sort of like, well, we call it metabolic because it affects your metabolism. It affects the way in which you metabolize nutrients. For instance, a lot of them originate from insulin resistance. So it's like a long-term condition that you can't really like take a drug and in the short term fix it. It's something you can take a drug long-term to help manage the symptoms. But the drugs don't necessarily treat the underlying issue when it comes to like chronic metabolic disease, which would be compared to like some other acute illness that perhaps you go to the doctor and they'll prescribe you a medication, you're on a short course of antibiotics or something like that, and your disease gets reversed, or you can become well. A chronic disease is something it's typically, related to lifestyle in some way, like related to nutrition. You end up with an underlying sort of underlying issue related to the metabolism of nutrients, and that in turn can develop into a specific disease state. I hope I described that in like a way that was understandable, but
No, it's something we talk about all the time on this show, and we don't often really explain the difference between those two things. So I really appreciate that explanation. That's wonderful. I wanted to focus our conversation today specifically on some of your latest research and your presentation, like we mentioned in the introduction. And I want to focus on the liver. And so let's start with an adult who is developing fatty liver. Classically, that's coming from an alcoholic. Can you tell us what is going on with the liver of an adult who's maybe an alcoholic and is developing liver disease?
Sure. So you wanted to talk about alcoholic fatty liver disease?
Yeah, I was hoping we could start there, so then we could talk about non-alcoholic and the difference there, and then how that is impacting children as well, who are obviously, hopefully, not drinking tons of alcohol at age 5, but how that's developing there. But I thought we could start with the adult and the classic kind of way that somebody would develop, liver disease through alcoholism.
Yeah. So I mean, at the end of the day, so the liver is an organ that is sort of like a master regulator of metabolism. So like a lot of the foods you eat are being metabolized by the liver. Like the liver is the primary site of fat oxidation. The liver is sort of like responsible for sort of converting nutrients into what you need, whether it's like through specific metabolic pathways where they're converting other nutrients into glucose or other nutrients into fat. So like the way in which alcohol is metabolized by the liver is essentially like through a pathway that is essentially taking that alcohol, converting it into fat while also suppressing fat oxidation. So over time, there's probably a combination of factors like inflammation, chronic inflammation and things like that just over time, that's like when this pathway is upregulated and this alcohol begins to be stored, converted to fat in the liver, and it stays there. It's being stored there. Also, like I said, because it's not being oxidized and used as a fuel. So that's sort of like the beginning stages of fatty liver when it's related to alcohol. Over time, when inflammation sets in, you end up with some degree of steatohepatitis that can develop into fibrosis in the liver. At the end of the day, the liver can no longer function appropriately when it has significant fibrotic tissue throughout. So that's sort of, I wouldn't say I'm an expert in the alcoholic side of fatty liver, but that it's, alcohol and certain nutrients are metabolized through similar pathways in the liver. So that's how you kind of draw these parallels between alcoholic fatty liver and non-alcoholic fatty liver, because there are some nutrients that are sort of going, being metabolized through a similar pathway as what the alcohol is doing.
Yeah, great. No, that was a perfect explanation that sets the stage to then talk about non-alcoholic fatty liver disease, or NAFLD. What is going on there, especially in an adult? We'll talk about children, obviously, but what is going on in an adult that is not drinking? How are they developing that disease as well?
Yeah, so it's similar in terms of like over time, certain amount of exposure to, and what we think is driving it is primarily like the intake of sugar, so glucose and fructose. High intake of these nutrients is sort of regulating these pathways in the liver that are converting those nutrients into fat. That pathway is called hepatic de novo lipogenesis, right? So it's the manufacturing of fat from sugar, essentially, in the liver. That upregulation in that hepatic de novo lipogenesis is suppressing the ability of the liver to oxidize fat. So what happens is, over time, the more that this is upregulated, the more likely you are to continue to store fat in the liver instead of burning it as fuel, like what would happen if glucose and insulin were low, fat oxidation's upregulated. It's sort of the opposite of that. So something else that also plays into it is exposure to free fatty acids, whether that's endogenous or exogenous free fatty acids. You combine that with the high sugar intake, and what you've kind of got is a perfect storm to just continue to store fat in the liver and end up with fatty liver disease, which is really, so non-alcoholic fatty liver disease is anything over 5% liver fat as measured by like an MRI.
Okay.
So it's a very low threshold for, anything over that. It means that your liver is shifting towards storing fat in a pathogenic way.
Interesting. Okay, so your slides in your presentation were absolutely beautiful. And I know you are an expert at imaging and looking inside somebody to see what's going on. And you were showing comparisons side by side of somebody that could have been even the same BMI. Maybe they're the same weight. Maybe they're the same height. They might look the same on the outside. So what? Who cares where people are storing fat? Does it really matter if I'm storing fat around my liver, or my arms jiggle and I'm storing fat there? Like, why does that matter where somebody's storing fat?
Yeah, that's a great question, and something I like to talk about too, because it kind of goes back to this idea, like in some of our earlier work, we looked at specific fat depots, and this idea of being metabolically healthy with obesity, which is a certain subgroup and phenotype within the individuals with obesity, which is a chronic disease in and of itself. But within that group, some people are protected against developing chronic metabolic diseases. And it's sort of, you can think of it like this, like subcutaneous fat, so the fat on your body that you can like pinch, fat that's distributed to the hip thigh region. Subcutaneous fat it's where lipid is supposed to be stored, right? So like if your subcutaneous fat is functioning properly and storing lipid the way it should be, in the context of like an energy surplus, that's sort of the healthy response, is to store fat there. And a lot of times those people that are really good at storing subcutaneous fat are protected against getting disease. It's when that subcutaneous fat loses its function, it becomes inflamed, it stops storing lipid appropriately, is when that lipid ends up in places like the visceral cavity, the skeletal muscle, the organs, the liver, the pancreas. It's that scenario when we begin to see the development of metabolic disease. So again, it's like could be entirely related to the function of your subcutaneous fat. When you lose the function of that and the lipid begins to be stored elsewhere, is when these metabolic sort of abnormalities begin to appear. It affects glucose uptake in skeletal muscle. It affects, the ways in which your liver is sensitive to insulin and responds to glucose and insulin. So it can even affect beta cells in the pancreas, right? So it's a big part of this whole, like the etiology of development of these chronic conditions.
Yeah, very interesting. So So with kids then, with kids that are developing some of these diseases, especially in fatty liver, and being diagnosed younger and younger, there's probably no way you could ever know this, but is it because these kids have a diet that's so poor when they're born, they start eating it so soon that they're developing sooner? Or in your mind, is it something more like generational? Now that we've had a lot of processed industrial foods for several generations and they're starting to kind of stack on top of each other, to you, does that feel like it's generational, and maybe the child from the womb is already being prepared to be expressed into this world that's seemingly full of carbohydrates, and maybe they're already insulin resistant at birth?
Right. Yeah, it's just such an interesting question. And while unfortunately, I don't have any conclusive answers on this. And I think there's a lot of interesting questions and questions that need to be answered. And I think there are investigators that are really interested in this particular question, this sort of idea of prenatal programming of a fetus, of, the metabolism of a child before they're even born could be being programmed in a certain way that sort of sets them up for these things when they're born, right? And I think that's a very valid hypothesis. How the maternal diet could be affecting the development, just things we don't really it's hard to study these things too, right? So but it's definitely it's a possibility. It's hard for me to think that there's something unique about what some kids are eating before they're 2 years old that could result in this, right? So there's something else going on in my mind, that it can't just be like what the child is eating alone before they're even 2 years old. Because there's more and more reports of kids younger and younger ending up with insulin resistance and type 2 diabetes type conditions. So yeah, so it's a fascinating question. And I think there's still a lot of work that needs to be done in that area before we can really pinpoint what's happening. So
yeah. Well, I appreciate the speculation. It is an interesting question. I don't know if we'll ever be able to answer it, but I appreciate you going there with me. So how young are kids presenting with fatty livers? Is it something that you are seeing in 2-year-olds, or is it something that it really needs a few years or maybe a decade to really start to establish itself?
Yeah, so I can say this, for our studies, we've seen kids, gosh, as young as 8 years old, that we've enrolled in our studies. Again, that we're looking we have specific inclusion criteria for our studies. When we're searching the medical records, we do encounter even younger kids that have, been diagnosed with fatty liver and have persistently elevated liver enzymes that's suggestive of fatty liver. So it's happening young. It's happening really young. Again, but our studies, I think our pilot study that we've done, we saw as young as 8 years old, though, that had pretty significantly severe fatty liver. Yeah.
Wow. And the diagnostic tools that you were describing to be able to diagnose this disease, am I safe in assuming that our diagnoses are probably just a very small fraction of the actual problem that's happening out there?
Yeah, I think that's a safe thing to say. And just speaking with adult patients with fatty liver, and even doctors, part of the thing with fatty liver is that there's no drug that directly reverses it. So, pediatricians, hepatologists do have to rely on lifestyle factors. So changing the way someone eats, exercise, all those things can help, reduce fatty liver. But it goes way underdiagnosed, especially in rural communities when, someone could go their whole life having elevated liver enzymes. Unless they're sent for an ultrasound, they'll never get a diagnosis. I've heard of adults who had been told almost their whole life they had elevated liver enzymes and ended up in the ER with liver failure because a lot of it's just some doctors don't diagnose it because there's nothing they can do other than tell someone, to change their lifestyle. So it's definitely a major problem. And I think from what I've seen, lots of kids go undiagnosed, and again, it's a multifactorial thing, the reasons why it's underdiagnosed. So, but it's definitely a problem. So I think even the rates that we see published and things like that are probably pretty, that's an underestimation.
Yeah. And I just think about the implications of having this at such a young age. Like, yeah, you definitely don't want this when you're 70, but when you're
Right.
7 and 8 years old, and now you're staring down the barrel of the rest of your life trying to maintain this disease, that has to be infinitely harder to try to do, right?
Right, exactly. And it's awful because a lot of times it progresses really rapidly in children. It can, a subset of people that develop NAFLD will end up with more advanced stages of it. A subset of those folks will end up with fibrosis and cirrhosis. And then, eventually as it progresses, liver transplant's the only option for some people. And for pediatric populations where this is sort of progressing at a more rapid rate, a lot of these kids might have to have a transplant by the time they're a young adult. If it's not addressed. So it's a very real and tangible sort of issue when it comes to looking at how diet is affecting our kids' health. So it's, poor diet quality is, a driving force in a lot of the progression of this. So
yeah, interesting. Well, okay, so let's talk about the studies themselves and the things that you've learned. Who came up with the idea for doing some of these studies, and what was the design like? And then also another question I want to know is how in the world were you able to get funding for this? The same with what we hear in the low carbohydrate world is there's no money for this kind of stuff. Dave Feldman, citizen scientist, is really trying to learn a lot about cholesterol to do his studies. It's us in the low carbohydrate community that are funding it. Like we're giving him literally hundreds of thousands of dollars so that he can do these studies, because otherwise no drug company, no food company has any interest whatsoever in doing a study like the one that he's doing. So again, what were the studies you guys decided to do and how were you able to secure funding for them?
Yeah. So the first study I did in pediatric fatty liver, I guess we published the results back in 2020. It was a 2-year pilot study that was funded by the Thrasher Pediatric Research Fund, which funds early career investigators to do, research as junior faculty, sort of considered to be a mentor type project. And then I was able to secure funding from the University of Alabama at Birmingham Diabetes Research Center that's funded by the NIH. So I kind of pulled these funds together, and I was able to do like a really nicely controlled pilot study that was a family-based intervention in these kids, where we were proposing carbohydrate restricted diet that was low in glycemic load. It was, this wasn't, I say our carbohydrate restricted diet wasn't like intended to be ketogenic or very low. It was like 90 to 120 grams per day, high in fat, matched for protein to our sort of standard USDA balanced diet approach that was low fat, probably 55 to 60% carbohydrate. Both diets in this study were intended to be high quality, so low in added sugar, and they were designed to be weight maintaining. So we really wanted to ask the question if we had 2 high quality diets that we specifically were manipulating the fat and the carbohydrate content, were one of these more effective at depleting liver fat in our kids. So that was our first pilot study that we did, and got our results published in Pediatric Obesity back in 2020. So then it was that year we went in for NIH funding, and we ended up getting around $3 million grant from the NIH to do a large, sort of scale up this project to enroll 80 families into a 6-month intervention where we're providing all the food to these families. We're doing really sophisticated metabolic testing where we're using like stable isotope tracers and the euglycemic hyperinsulinic clamp to measure insulin sensitivity, and doing all the MRI testing at multiple time points. So the NIH, like I'm very encouraged. We've had a lot of success getting funding from the NIH and our lab group to do these types of diet interventions. I have a collaborator also that was able to get a large grant from the Department of Defense to look at a low glycemic carbohydrate restricted diet in multiple sclerosis. So really these funding agencies are, we've had success getting these like lower carbohydrate low glycemic load diet studies funded, you know, because at the end of the day, like we have pretty solid preliminary data. There's a strong body of evidence to suggest that this could be an effective therapy. So, you know, I'm pretty hopeful, and I think like everyone should be sort of excited about this, that you know, the funding agencies are supporting these types of research projects.
That is just nothing that I have ever heard in the past from anybody. That is so encouraging to know that yes, there is funding for this kind of thing, and they do want to know some of these answers. It sounds like that has absolutely been your experience.
Yeah.
Amazing.
It's been great. Yeah.
That's amazing. Okay, so in these studies, you're actually giving people the food. Is the food cooked? Is it prepared? How are you practically able to do this? I think most people understand that doing any kind of study in nutrition is very, very difficult. It's going to be very expensive. You know, how do you know that people are eating the food? A lot of it is based on epidemiology, where we're just asking people to fill out these silly surveys and try to remember all the food you've eaten in a year, which is literally impossible. Like, how are you able to, how are you able to like give people the food and make sure that they were compliant?
Yeah. So, you know, I consider what we're currently doing, I call it like a modified controlled feeding study. So, you know, a controlled feeding study in the nutrition science world means you have a metabolic kitchen. They measure every food item out to the gram. They prepare it, they cook it, they hand it to the participant. Every single meal and snack they're supposed to eat in a day is provided by this metabolic kitchen. And we've done studies like that in the past. And that's sort of like a gold standard in the, you know, controlled feeding realm of doing tightly controlled nutrition intervention studies. This study that we're doing now, you know, using a metabolic kitchen costs a lot of money. If we intend to feed an entire family for an extended period of time, we sort of had to come up with a more like cost-effective way of doing that. And also, I think there's value in doing what we're doing. And so to back up a second, like what we're doing in our study now is, again, I would call it modified controlled feeding. So they meet with our dietitians on a weekly basis. They get a menu, they get recipes, they get exactly how much of something they're supposed to eat, particularly for the child, since they're the ones we're, you know, measuring the outcomes on. And then the dietitian uses a grocery delivery service like Instacart or Shipt and orders all of the groceries for the family, arranges it for it to be delivered to their house that aligns with the menu that they've been provided, and specific instructions on how to prepare the food and how much of it to eat. So we try to make it, I think there's like an educational piece to this when the families are actually getting groceries and seeing what types of foods to order or what types of foods to purchase when they're doing this on their own. Having sort of like recipes and menus to fall back on is a very valuable experience, I think, to a lot of the families and the kids, right? And learning what types of foods are like the best, you know, best for my condition and my disease. I like to sort of tell, you know, I like to like frame it like every disease, like whatever disease your child has, that's a family disease. You have to approach it and support that child and approach it in a way that's going to have them, you know, have the greatest likelihood of succeeding and sticking to it, and understanding that this has to be sort of a new way of life, right? To be able to continue to see these consistent metabolic improvements and sort of stave off any sort of other chronic disease down the path. So anyway, that was like a long-winded way of saying that, like, yes, so we deliver groceries to the families and do a lot of counseling with them with our registered dietitians that work for the study.
Amazing, very comprehensive.
Mm-hmm.
When I interviewed Dr. Stefan von Vliet, he lives near me. He lives up in Utah State, so it's about a 2-hour drive from me, and he has a metabolic kitchen at the Utah State University. And to be able to see it up close and personal, like you have, you know, your kitchen facilities and the area where you're giving people the food, whether it's being delivered on a daily or weekly basis or a per meal basis, and then, you know, walking through all the different labs and all the Bunsen burners and all these complicated scientific instruments to kind of parse out nutrients was really fascinating to see. And again, it just goes to show how difficult it is to do some of these nutritional studies. So you're talking about the kids and you're talking about the families, and I think most people would just guess like these people are not going to be compliant. They are already overweight, they're already expressing chronic disease, they are, lazy, or they're just not going to follow the advice. For you, what was your experience working with these families? Did it seem like people were eager to learn about this stuff, and were they actually giving this a really good try? Or was it something that they were like, yeah, we understand, but pizza just tastes too good?
Yeah, that's a great question. And so what's so like cool about the study, and our pilot data showed pretty well that, the kids lost liver fat, like they actually stuck to it, right? We got the results that we hypothesized we would see. So, and the feedback we got from the families was like, they felt so much better, right? They actually enjoyed being in the study. They liked the food. They liked eating the food. A lot of times they were like, wow, this is like so much food. It's like almost too much food to eat, but it's like, they enjoyed it and they didn't feel deprived, and they felt healthier. Like, we weren't collecting data on the parents, but the parents were like, I've lost weight. I feel great. Like, our kids super happy. Like, seemed like an overall great experience. And like in our larger trial that we're doing now, we're getting that same feedback where the kids even, when they're meeting with our dietitian, they're just like, we thought this was going to be so much harder than it is, but like, we like the food and we like the diets, and, it's been, so, we get such good feedback, and, that's the point of doing like a pilot feasibility study, right? Like, we can design whatever study we want, but if people can't stick to it, people can't do it, then, we don't want to dump a lot of money into doing like a larger version of it if we can't pull off a small trial. So like the pilot proved to us that the kids stuck to it, and the kids that were in our pilot trial lost a third of their baseline liver fat just in 2 months. Like, that's a really short amount of time. I was surprised, like, and happy, and I thought it was great that, we got such great feedback about, and that people wanted to stick to the diets because they liked it. So
that's amazing. Anecdotally, I could say in my career, that has been my experience as well. It's not necessarily that people are non-compliant because they're just lazy and they just really like unhealthy foods. It's that they're getting the wrong information, the wrong message is being sent to them, but they are actually trying. They just don't understand why they're having so many cravings for things that they know they shouldn't be having, and why they keep falling into the same pitfalls. And they just blame willpower. They think they can't stick with it, when really it's more of like an information kind of a vacuum, in my opinion. So you've already mentioned some of the things that you've learned from the study. What were other conclusions that you came to after doing these studies?
Yeah, so it's interesting, and how I ended up in the fatty liver space, I guess, is to back up a little bit, is in the previous studies we've done, when we used a metabolic kitchen and adult studies, essentially like the hypothesis was that we could deplete the metabolically harmful, which would be liver fat, right? That ectopic and visceral fat, we could deplete it just by manipulating the macronutrient composition of the diet. So we did a couple of adult studies, one in PCOS, one in adults with overweight and obesity. We found that in 8 weeks, in the absence of weight loss, on a low glycemic load, moderately carbohydrate reduced diet, we saw depletion of visceral fat. We saw depletion of intermuscular fat. So essentially depletion of these like metabolically harmful fat depots in the absence of significant weight loss. So it's like that result alone, it's like, so we're actually improving metabolism, we're improving metabolic health, has nothing to do with weight loss. So moving forward into the pediatric space, it was like, this is a perfect population to test this hypothesis in. Can we deplete this ectopic lipid from the liver in the absence of weight loss and see improvements of metabolic health? So it's part scientific question, right? It's part just like a cool hypothesis. But then also, how does that translate into real world application? Like, because people do want to lose weight oftentimes. But the question is it necessary? Should that be the goal? Should weight loss be the goal, or should improvement in metabolic health be the goal? And I think the way you get there, the way you frame, changing lifestyle affects the way in which you're, able to adhere to it. So I think, just look, that sort of, that whole area, the way in which I'm able to take like my expertise in imaging and looking at like lipid deposition in organs and the adipose tissue distribution and the way in which macronutrients can affect that is sort of what led me into this space in the first place. So I think, there's what I've found at the end of the day is that there are many different types of lower carbohydrate diets that can be effective at treating different metabolic diseases and also work in a prevention sense. So I think it's just, that's sort of how I sort of ended up in this particular research space.
Very, very cool. And just to reiterate, we're not talking about an extremely low carbohydrate diet. You're not doing what, I've done for 4 years, which is a carnivore diet, where I essentially have zero carbohydrate in my day-to-day diet. That none of that is what you were doing. It's just a moderate kind of low-ish amount, lower than most people would be eating in carbohydrate, correct?
Right. So I've done, I've actually looked at multiple different types of carbohydrate restrictions. So like the studies I was just describing in adults with overweight and obesity, and then the women with PCOS, that was a low glycemic load diet, 40% carbohydrate versus the control, which was 55% carb. So it's still, to a lot of people, that's pretty high carb, 40%, but we were still able to see a difference compared to 55% carbohydrate. The kids study we're doing is much lower. So it's like 25% carb or lower. So like I said, like a range between like 90 to 120 grams per day, depending on their energy needs and the kids studies. Then I've done like work using a ketogenic diet, looking at changes in body fat distribution in older adults with obesity. So I'm talking like adults average age like 70 that have obesity and have like a body fat distribution pattern that's characterized by really high visceral fat, high amounts of intermuscular fat that can affect function and quality of life. So I've done interventions using a ketogenic diet in older adults as well, and saw like really interesting results in terms of depletion of visceral fat and the intermuscular fat in older adults.
Very interesting. So how have these studies been received? Were people pretty excited about the results?
Yeah, I think so. So I presented, like I try to present the results like at, the conferences like American Society for Nutrition. We go to American Diabetes Association, the Obesity Society. They're well received. I'll say, the older adult study, the ketogenic diet study that was published in Nutrition and Metabolism was, it got a lot of views. So that was a popular one, I think. And I think they're pretty well received. And we've had a lot of success, like continuing the funding stream with the NIH based on our results from a lot of these trials.
Interesting. So that's a really good point. I've been in the low carbohydrate space for so long that that's kind of my space. Like going to Low Carb Denver is all of my people. I don't know what it's like at some of these other major medical conferences. In your experience, are people like talking about ketogenic diets? Are they aware that there's people out there that are doing very low carbohydrate, maybe keto or carnivore? Like, is there an awareness of that in like a more generalized medical, convention when you attend those?
Yeah, I mean, I'd say there's always a group of folks that are either presenting, their abstracts or their data, and that sort of thing. It's a lot of times it's a topic for a debate type format, depending on who's invited to speak that year. I've given talks at some of these meetings about the ketogenic diet, and then it's sort of like, obviously you're gonna have, within any like nutrition organization, you're going to have people that have very different views, right? Like the camps of people that may or may not agree with certain dietary approaches, and everybody sort of has their own thing that they're researching. But in general, I feel like over the years since I've been doing this, it's like it's becoming more and more accepted. I'm getting, I go and speak to different dietetic association groups. I speak to student groups. I go speak at different universities for undergraduate programs and graduate programs, sort of introducing this information to dietetic students. So it's really like, it's been a slow, it's been slow going in some regards, but I do think it's becoming more widely accepted as a, while some people don't think it's like the only healthy way to eat, I think it's being accepted that this is definitely a healthy way for a lot of people. This is like the way they are finding their optimal health. It works really well for specific conditions like type 2 diabetes and fatty liver. Like, I think that information is being more and more widely accepted, that it's one of many ways that people can achieve like optimal metabolic health.
Yeah, very cool. I always wonder about the younger generation because they've been listening to Joe Rogan for a while now. You know what I mean? Like, they would have been at least introduced to some of these concepts. So I'm hoping that they will be more open to, at least, again, like you said, this isn't like the only thing you can ever do in nutrition, but this is a viable option for certain things.
Right.
So I love that. What are kind of the next studies that you will want to do? Like, has this opened up more doors for you to continue study in this field? Like, what are you working on for the future?
Yeah. So right now we have multiple studies that are ongoing. So we have one that the results should be coming out relatively soon in adults with type 2 diabetes, where we're doing low carbohydrate compared to low fat, looking at beta cell function and pancreatic lipid, with this hypothesis that like the lower carbohydrate approach in type 2 diabetes will selectively deplete pancreas lipid and sort of cause the beta cell function to spring back over about a 3-month time period. We're wrapping up that trial soon, so results should be forthcoming. We've got I mentioned it earlier, a study that we just got started, funded by the Department of Defense, in multiple sclerosis by one of my collaborators, that we're measuring similar things. We're doing MRI, looking at MS-related outcomes to see if a low glycemic, carbohydrate-restricted diet can sort of improve symptoms related to MS. I've got another investigator that I work with that we're looking sort of in like the cancer space. So several projects ongoing related to that. So we've got a lot of different areas, different disease states and different conditions where we think a low glycemic, carbohydrate restricted diet that's high quality could be a really effective treatment for a lot of different things.
Interesting.
Yeah.
Wow, that's super cool. Okay, so but let's get personal. For you, Dr. Amy Goss, doing all this work and all this research, has your own lifestyle changed because of any of the research that you have done? Have you thought about your diet any differently, and what would be like a normal day of eating for you currently?
Sure. Okay. So I'll say this. So I guess part of the reason, and I don't mind sharing this, that like I've had type 1 diabetes my entire life, right? So I was diagnosed when I was 2. And that sort of, I had to learn how to read nutrition labels at a very, very young age.
I didn't know that. Wow.
Yeah. So sort of avoiding sugar was like, has been my MO since I can remember, right? I don't ever remember not, thinking about this. So it really was I guess I was in college and undergrad when I really started. I think the first book I picked up, as someone that has type 1 and you're like, you have to count all the carbohydrates you eat, bolus insulin throughout the day. You're very aware of like the effects of what a really high carbohydrate and insulin dosing regimen how it affects you and how it makes you feel. So I've really followed like a low glycemic approach since I was like in my early 20s. So a long time now. And it's interesting because, I just did it. I read Sugar Busters, sort of started doing that. And then going through dietetics, the dietetics training in undergrad, some of the things that you're just like taught to, teach people with type 2 diabetes or someone with heart disease and those types of things didn't really align with like a lot of the stuff that I knew to be true for myself when it came to type 1, right? So it really was like that sort of steered me into the research space, I guess. And so that, it's still sort of, I don't do There are probably days when I eat lower carb versus higher carb. In general, I try to stick to a pretty low glycemic diet.
Well, that is a wonderful answer. I actually didn't know that you had type 1 diabetes. So thank you so
Yeah.
much for sharing that and sharing your journey. This has been an awesome discussion. I've certainly learned a lot, and I think the listener will really appreciate the level of detail that you've gone into this topic. Dr. Amy Goss, where would you like people to go to find you and connect with you in your work?
Sure. Yeah. I always forget to like drop my social media handles, but I'm on Twitter at Amy M. Goss. And then I also more recently started like an Instagram account that's Dr. Amy Goss. So you can find me on either one of those spaces. We also, my lab group is releasing a website soon where we're going to list all of our ongoing clinical trials. We're going to give you access to menus and food lists and recipes that we use in our studies. If anyone's interested in like following a fatty liver diet or some, one of our things that we're trying to test in our studies. So that website is going to be called Diet for Diabetes, and it's linked to the UAB, the overall UAB page. Let's see. And that's it. And we also soon we may be offering like virtual counseling sessions for anyone that's interested, where you can request to meet with one of our dietitians virtually, and then we can hook you up with like a nutrition evaluation and some more help in doing some of our diets.
Very, very cool. That's an amazing resource. We will definitely link all of that in the show notes. And I'm so glad you did this too. In your presentation, you had an entire slide that was acknowledgements where you showed your entire team and all the people that you're working with. And I know it's not just you there that's doing a lot of really hard work in this area, but a whole team. So we're just so grateful for you and everybody at your lab for all the work that you're doing, and to get this information out and be presented to the public is amazing. So thank you so very much for everything that you do and for taking time out of your very busy schedule to come on our show today. We really appreciate it.
Yeah, thank you so much. This is great. So great.
Absolutely. Great to talk to you too. And this has been another episode of Boundless Body Radio.